Recurrences, this is an older EORTC calculator. And recurrences, that's quite well. You see that in high-risk patients after 5 years, 80% have recurred. They keep on coming to your outpatients, you keep on seeing those patients, etc., etc. Those are lifelong commitments. And progression, that's without the use of BCG, used to be calculated in the worst group as 45%. Well, I think that's a bit high. It has been updated, so here that it's more in the range of around 20% progression in 5 years. But still, 20% of those patients will get an invasive tumor and need cystectomy. 1 in 5. That's not nothing. And here you see also that's a realistic number there. You see progression, 5-year, 22.8%. So around 20% progression, I think, if you treat them well, still 20% will progress. That's a realistic number. Oops, one back. Yeah, very good. And here you see more or less the same. An updated EORTC study showed after 5 years 20%. So keep that amount in your mind, around 20% progression for those patients. And that's something you don't want to miss. How long? Well, NICE says 1 year is enough. Well, these were patients with low-grade tumors, TA low-grade. That's really the lowest of the lowest. You still see that there is a 5-year recurrence rate of around 40%. Some do progress, and even some patients die of bladder cancer with low-grade disease. So should you stop after 1 year? I don't think so. But that's the NICE recommendation. And the long-term fate, here again you see low-risk patients, 2.4% died within almost 10-year follow-up. So they're a bit innocent, but they're not completely innocent. Just keep that in mind for your follow-up. And this is very funny. Patients that have not had a recurrence for 5 years still get recurrences after that. These are studies looking at patients free of recurrence for 5 years. Look then what happens. You see that between 10 and 15% of those patients still will get the recurrence. I just saw a guy last week who was 50 years without a recurrence, came in with hematuria, and again had a large bladder tumor, although I checked him every year because he wanted that. And actually he was right. And how do we do follow-up? Cystoscopy and cytology. So actually the conclusion is, probably we do in some patients too much, the low-risk patients. I guess NICE does not do enough, the UK. Tools are actually, we have to admit it as urologists, we have to be honest, they're of low quality, and the level of evidence is extremely low. It's all expert opinion. So are urinary markers a solution? And to be honest, I spent the first 10 years of my academic life looking at all kinds of markers. The BETA STAT test, the BETA TRAC test, the NP22 set, all kinds of stuff. And they never were what I expected.